Okay, let's dive into something really urgent and deeply human today. We're looking at a crisis that, well, it really captured global attention starting back in late 2013.
You mean the huge increase in people migrating to Europe?
Exactly. Often taking those incredibly dangerous routes across the Mediterranean. The numbers are just stark.
Yeah, the source mentions nearly 9,500 people reported lost or died just between 2014 and May 2016.
It's horrifying. And in early 2016, it was estimated like 1 in every 23 immigrants on those routes died.
A scale of human movement and suffering that really forces us to look at how societies respond.
And that's our mission today, isn't it? To understand a specific, really critical part of that response.
Right. How the health needs of certain migrant groups, we're talking specifically asylum seekers, refugees, and undocumented migrants, how those needs were addressed, or, well, not addressed.
Through social policy in Europe, how did countries actually translate those, fundamental human needs into social rights and practical help?
And we're zooming in on two specific countries, Sweden and Germany. They both saw massive numbers of arrivals and asylum applications then.
We've got a pretty detailed academic analysis and some key Eurostat data visuals to help us sort of cut through the noise here.
Yeah, the goal is to really understand the different paths they took, figure out why they were so different, and what the real impact was.
Could migrants actually get the health care they needed? And we're sticking strictly to the material provided.
Absolutely. So maybe let's set the scene a bit more. Migration itself isn't new, obviously.
No, it's always been part of human societies.
But the scale after 2013, especially people coming from Syria, Afghanistan, Iraq, it was huge. That's what triggered what people started calling the refugee crisis in Europe.
And you had things like the EU's Dublin regulation.
Yes, the rule that you're supposed to seek asylum in the first EU country you land in.
Which the sources say basically wasn't widely followed during the peak of things.
Not really, no. People kept moving. And interestingly, the material points out that some EU countries were just more attractive than others.
Why was that?
Well, partly networks, friends, family already there,
Yeah.
but also, crucially, perceptions about how countries treated asylum seekers and refugees.
And even your country of origin could apparently affect what you might be entitled to.
Exactly. It adds another layer of complexity.
Yeah.
And the term migrant itself is super complicated, isn't it?
Yeah, the source lists so many categories. Regular, irregular, short stay, long stay, victims of trafficking, asylum seekers, refugees, displaced, undocumented.
It's a real mix. For policy, they often get grouped as non-citizens. Though, the source reminds us, migrants could also be citizens, of course.
But whatever their specific label, the material stresses they often face, well, unexpected struggles after arriving.
Like discrimination?
Discrimination, problems getting their status or qualifications recognized, and big problems accessing basic welfare.
And a key issue highlighted is that gap between their actual needs and what's provided, even if the international rights supposedly exist on paper.
Right. And just to be clear for everyone listening, this deep dive is really focusing only on asylum seekers, refugees, and undocumented migrants. We're excluding other groups for now.
Which helps us examine the policies that came about specifically because of that crisis context.
Okay, so a critical point from the source is this growing divide in healthcare access between migrants and non-migrants. It's driven by social policies.
And that raises big questions about equality, about equity. You have international laws, like the Geneva Convention, granting refugees civil and social rights, sometimes even the same as citizens.
Well, the national policies, they can be wildly different.
Totally. The source argues that the interaction between the state and the foreign national is really the key thing.
And that interaction is heavily influenced by citizenship status, right?
Hugely. Citizenship is presented as a major factor determining who gets state welfare. It draws a line between citizens and non-citizens based on nationality and immigration status.
Refugees are even called a special kind of foreigners in the material.
Yeah, because their relationship with the state is seen as unique, conceptually linked to that old idea of the ruler and the ruled, just like citizenship itself.
And looking at the EU level, you've got freedom of movement, but that's mainly for EU citizens.
Right. For non-EU migrants, border controls and, critically, national policies have a massive impact. Accessing welfare is highlighted as a really key area where they face limitations.
And the rules for things like immigration, getting citizenship, they vary so much within the EU.
Which creates all these new disadvantages or advantages depending purely on which country you end up in. And this is crucial.
What was that?
The Treaty of Lisbon, back in 2009. It explicitly says that social policies defining needs, rights, turning them into policy that remains principally the responsibility of the member states.
Ah, so that's why we see such big differences between countries like Sweden and Germany. It's baked into the EU structure.
Exactly. National governments hold the cards on social policy and health, specifically.
Yeah.
Well, the source notes it's not always seen as a universal need, or it's organized in really complex ways within the welfare mix.
And reports consistently show immigrants are often more disadvantaged when it comes to health outcomes.
So circling back, why Sweden and Germany specifically? We mentioned the pull factors, networks, perceived conditions.
But the numbers themselves are just really striking.
They are. If you look at the Eurostat data, graphics 2 and 3, wow. In 2015 alone, Europe saw over 1.3 million asylum claims.
And Graphic 2 shows Germany was way out front for first-time applicants. It peaked around 450,000 in 2015.
Massive numbers. And Sweden was third, with about 160,000 applications that year. Proportionally, that's huge for Sweden's population size.
So the numbers alone make them critical cases.
Definitely. But the most crucial reason the source picks them, it's their fundamentally different ways of organizing welfare, their welfare state models.
Using that Esping-Andersen framework, right?
Exactly. Sweden is your classic social democratic regime, built on universal human needs, aiming for universal social rights, equality through big public provisions.
And Germany.
Germany fits the corporatist model. Social rights there are more differentiated, tied to your job, your contributions, different segments of society.
So that core difference in philosophy and structure really sets the stage for everything else.
Precisely. It explains why their policy responses to the same crisis were so distinct.
Okay, so to really grasp how needs get turned into rights, the source brings in some academic frameworks, particularly Dean's work.
Yes, Dean's ideas on needs, rights, and social citizenship are central here. Let's forget the policy jargon for a moment.
Good idea.
At its heart, it's about basic human needs. Dean and others cited talk about needs for survival, obviously, but also for human flourishing.
They mention thin needs and thick needs.
Right. Thin needs are the bare minimum for survival. Thick needs are about what it takes to be a fully functioning human being. They need more interpretation.
And these needs can be seen as inherent just because you're human.
Or interpretive, understood through experience. But a key idea from Doyle and Goff is that physical health and personal autonomy, being able to act for yourself, are presented as universal prerequisites for any human action or interaction.
So needs are the bedrock. What about rights? How does Dean see those?
Not just as dry legal rules. Dean views rights as relational, deeply tied to how interdependent we are as humans. Social rights, in this perspective, are basically recognized human needs that a society has kind of agreed upon and negotiated.
Negotiated, okay.
And how they're negotiated leads to different kinds of rights. The source mentions contractarian versus solidaristic rights, linking back to those thin and thick needs.
Which brings us to Dean's framework for social citizenship, graphic 5 in the material.
Yeah, it's built on two dimensions. First, sociality, basically, your sense of belonging to a group, how interdependent you feel.
Okay.
And second, negotiation, the ways, formal and informal, that needs and rights get discussed and decided, the rules, the dialogues.
And Dean's big idea.
That citizenship itself isn't just a legal status. It's something society constructs. It's based on who we see as part of the group. And social citizenship is the ongoing process of negotiating human needs within that group.
So it's not fixed. It's constantly being debated.
Exactly. It's an invention, constantly contested based on how thick or urgent needs are perceived. This builds on older ideas, like T.H. Marshall talking about social rights becoming part of citizenship in the 20th century welfare state.
Okay, and if we look at Dean's combined framework in graphic 4, linking needs, rights, and citizenship approaches, the source points to the humanitarian approach as being particularly relevant for migrants.
Right. This approach really emphasizes universal needs, the idea that certain needs are just human, period.
And meeting them is
a moral imperative. Rights flowing from these needs are seen as axiomatically all-inclusive, in principle at least, even if policies often restrict them to citizens.
And crucially,
it implies entitlements are a collective responsibility. Society as a whole has a duty to ensure these basic needs are met.
That sounds like the ideal, like the Universal Declaration of Human Rights. But the source throws in a bit of cold water, doesn't it?
It does. It notes the very real debate about whether universal social rights can ever be fully achieved globally. Some scholars apparently call it a utopian aspiration.
Highlighting that yawning gap between the idea and the reality.
Exactly. States have obligations under international law, respect rights, defend them, work towards achieving them, but globally, the capacity and the actual experience often fall way short.
And this ties into the difference between positive and negative rights.
Yeah, positive rights require action. Someone has to provide something, like healthcare or welfare. They need organizations, funding, redistribution. They're about freedom from deprivation.
Whereas negative rights are more about freedom from interference.
Right, more individualistic. And entitlements, the source notes, often get used like rights, but specifically carry that emphasis on equality you find in positive rights.
Okay, that's a really helpful theoretical grounding. So armed with that, let's look at the practice. How did Sweden's universal approach versus Germany's corporatist one actually play out for migrant healthcare access during this crisis?
It's a fascinating contrast. Sweden, as the source lays out, has a long history as a migration nation. They received a very high number of refugees proportionally during the crisis, high protection rate in 2015.
Though you mentioned changes later, in 2016.
Yes, important to note, parliamentary changes approved in June 2016 did affect conditions for asylum seekers later on, but focusing on the period around 2015.
Their healthcare system is the classic National Health Service model, right? Publicly funded.
Mostly, yes. Run by county councils, though politically centralized. Strong focus on public health equity. The guiding principle is healthcare as a right, regardless of income.
They even had specific laws aimed at migrants, like the 2008 Act for Asylum Seekers.
They did. But here's the crucial part where practice diverges from the universal principle. Access was explicitly tied to legal status.
So despite the universal ideal, the policy created tiers. That's a key finding.
Absolutely. If you were a migrant with short-term residency or an asylum seeker waiting for your application, you were ineligible for most welfare provisions unless you were staying for a year or more.
And adult asylum seekers.
Legally entitled only to care that cannot be postponed. So emergency care, essential things like maternity care, abortion, contraception counseling.
But there was an exception for children.
Yes, a significant one. Asylum-seeking kids and undocumented children under 18 got the same access as resident kids. No statutory conditions mentioned there.
What about undocumented adults?
They had a right only to non-subsidized urgent care, which, the source notes, means facilities were limited and they could be excluded if they couldn't afford to pay.
So even in Sweden, with its strong equity principles stated in their Health Act from '82, human dignity, need, and solidarity, cost-effectiveness, and their public health strategy.
The actual policy created real barriers based on legal status and ability to pay.
Yeah.
Kind of contradicts that pure universal ideal.
And the source connects this to the fact that migrants, even in Sweden, face higher risks of poverty and unemployment.
Right. It cites figures like only 22% employment for low-educated immigrant men and just 8% for women in one study. If you're poor and facing user fees or other costs, those universal principles don't help you access care.
Okay, so that's Sweden. Now let's pivot to Germany. Starts from a very different philosophical baseline.
It really does. The source notes that migration wasn't traditionally a big policy focus there compared to, say, health inequalities within the existing population. Migrant health access just hadn't been advanced as a particular policy subject.
And their healthcare system isn't an NHS model, it's insurance-based.
Correct. Mandatory social insurance, mostly through nonprofit sickness funds plus private insurance options. It values solidarity and patient choice, but also has this strong tradition of self-organization, volunteerism, family support.
How does it work structurally?
Funding and provision are separate. The payers, the sickness funds, have contracts with the providers, doctors, hospitals. It's corporatist, meaning certain institutions with compulsory membership get significant rights in managing money and negotiating contracts.
And the principles guiding their main statutory health insurance, SHI.
They include maintaining health as care, being needs-based, reflecting solidarity, but also, very importantly, cost efficiency.
Cost efficiency. What does that mean in practice?
The source quotes the principle. Services must be adequate, appropriate, and economical, and shouldn't exceed what is necessary.
And this insurance model fundamentally shapes who gets access, doesn't it? Unlike Sweden's citizenship-based idea.
Exactly. Access in Germany is primarily insurance contribution-based. It's tied to your participation in the system.
Which creates what the source calls an individualized or customized right to health care.
Right. While the aim is near universal coverage, your specific access and entitlements are linked to your insurance status or contributions. The source doesn't list specific migrant health laws like for Sweden, reinforcing that it wasn't a targeted policy area in the same way.
So the main limitation seems baked into the system itself. If access depends on contributions or status, differences are inevitable.
Pretty much. And that focus on cost efficiency in the SHI could potentially influence the range or level of services provided, although the source doesn't deep dive into specific examples of that.
Okay, so let's synthesize this. We see these two different welfare regimes leading to different outcomes. The source mentions research suggesting universal states like Sweden tend to do better integrating non-citizens.
Yes, that argument exists, citing Sainsbury and others. Universalism, in theory, should make it easier.
But our deep dive into the source material shows it's not so simple, right? Even in universal Sweden, the actual policies created status-based exclusions, especially for short-term or undocumented people.
Exactly. The ideal didn't fully match the reality described. And in Germany, the insurance model itself inherently creates barriers linked to contributions or status, even while aiming for broad coverage.
And the source reminds us healthcare policy is always controversial territory.
Deeply. It involves regulation, redistribution, life and death decisions, huge amounts of money. It's always political.
So, to recap the core difference, Sweden's entitlement is conceptually tied to citizenship, a universal view of need. Germany's is more of a conditional earned claim based on insurance and contributions within that corporatist system.
And their funding provision models reflect that. Sweden's integrated public NHS versus Germany's separation of funding and provision linked by contracts.
And these underlying principles, equity, solidarity, individual responsibility, they shape the whole welfare mix.
Right, and the source raises a really interesting point about market forces.
What is that?
That market-oriented approaches, whether in Germany's insurance system or market dynamics being introduced in Sweden, might actually end up obscuring real human needs. They can focus more on wants, what people can pay for rather than fundamental needs.
Which brings us back to those financial barriers. User fees, insurance costs.
Especially tough for migrants who, as we saw even in Sweden, are often at higher risk of poverty. Restricting access based on ability to pay inevitably hits the most vulnerable the hardest.
And there's a final concern raised about privatization.
Yeah, the idea that increasing privatization can make it harder for governments to steer the health system democratically or adapt it effectively to big challenges like increased migration.
So pulling it all together, what's the main takeaway from this comparison?
I think it's pretty clear. Policies based on citizenship, legal status, or different insurance schemes inevitably create systematic differences in healthcare access. This leads to inequities. Access should ideally be based purely on need, not these other conditions.
But measuring this gap is hard.
Very hard, the source admits. Lack of specific migrant data, different definitions used by countries, varying categories. It makes a clear, comprehensive analysis really challenging.
So the ideal, according to the source's argument, would be that humanitarian approach.
Yes. Translating human needs universally into an inclusive welfare system that covers everyone physically present in a country without discrimination. It's intuitively attractive. Similar needs should mean similar rights for everyone.
But the reality is that current systems weren't really built for this.
No, they were largely designed with citizens and long-term residents in mind. They're struggling to adapt to increased migration and just the changing face of society.
So the conclusion is adaptation is needed.
Fundamentally, yes. Countries need to reevaluate. They need to recognize human needs more universally and find ways through what the source calls new negotiations to develop comprehensive solutions that actually address the health needs of everyone within their borders.
It leaves us with a pretty big question, doesn't it? Considering how deeply national welfare systems are tied to these ideas of citizenship, contribution, belonging, and facing the ongoing reality of global migration, how can countries genuinely shift? How do you move from systems designed mainly for us towards that truly humanitarian approach, where essential needs, like health, are met for everyone, regardless of their legal status? That seems like the fundamental challenge for social policy today.